Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Racial, Ethnic Differences in Breast Cancer Patients' Preferences and Experiences with Genetic Testing by Reshma J.C. et al. My name is Jennifer Axelbund, and I am a genetic counselor and assistant professor of oncology at the Johns Hopkins University School of Medicine in Baltimore, Maryland, USA. My oncologic specialty is inherited cancer syndromes. This study is a longitudinal cohort study of women diagnosed with stage 0 to 3 breast cancer in metropolitan Los Angeles and Detroit, as reported to the NCI's SEER registry. Approximately 2,300 women responded to the baseline survey and 1,500 to the follow-up survey 4 years later. Latina and Black patients were oversampled to ensure sufficient minority representation, resulting in 17% of the respondents being Black and 39% being Latina. 42% had a high school education or less. A little over one-third of respondents expressed a strong desire for genetic testing, and this desire was more common in younger women, Spanish-speaking Latinas, and those with a family history of cancer. Over 80% of Spanish-speaking Latinas also expressed high levels of worry that other family members might get breast cancer in the future. Of the approximately 500 patients who expressed a strong desire for testing, about 200, or around 40%, did not report having a relevant genetics discussion with a healthcare professional. The authors refer to this as unmet need for discussion. Minority patients were more likely to express unmet need for discussion, and Spanish-speaking Latinos were nearly 5 times more likely to have unmet need for discussion about testing than white non-Latina patients. Worry about local recurrence, contralateral new primary, and or distant metastases during survivorship was double in those with unmet need for discussion, 49% versus 25%. About 40% of patients with a strong desire for genetic testing actually had testing, and those who received testing were younger, more likely to be white than Black, and more likely to have a family history of breast or ovarian cancer. It is generally accepted that 5 to 10% of breast cancer has a significant hereditary component. Characteristics of hereditary breast cancer predisposition include young age at diagnosis and a family history of breast and/or ovarian cancer. Therefore, it is reassuring that the respondents who actually underwent genetic testing were younger or had a family history. However, this study highlights the discrepancy between perceived risk and actual risk. As the participants were identified through SEER registries, one would assume that the majority of respondents were not appropriate for genetic testing. Yet, depending on race and ethnicity, up to 60% of respondents had a strong desire for genetic testing, whereas only around 10% would be expected to actually meet indications for testing. This is arguably attributable, in large part, to lack of understanding of breast cancer genetics. The majority of patients, and especially those with lower medical literacy, likely do not realize that a very small proportion of breast cancer is able to be explained by currently known genes. Thus, desire for genetic testing is expected to exceed 10%, but 60% is substantially higher than one might predict. Another contributing factor, as the authors point out, is ongoing media coverage of breast cancer genetic testing. Much of this coverage focuses on sensational issues, such as prophylactic mastectomy in young, healthy women, rather than the limited utility of current genetic testing to truly define risk. Therefore, inundation with genetics information, but without context, presumably contributes to a higher desire for genetic testing. As a result, the authors conclude that all patients, regardless of indication, may potentially benefit from a discussion about genetic risk. The authors also note a correlation between unmet need for discussion about genetic testing and long-term worry. This worry was particularly pronounced among Spanish-speaking Latinas, which is a population expressing a stronger desire for genetic testing. Of note, the patients express worry about issues that are not genetics related, such as metastasis. Therefore, this also suggests lack of understanding of the role that genetics plays, with patients potentially mistakenly thinking that genetic test results determine disease prognosis. This highlights another reason that genetics should be discussed with all patients. Specifically, it provides an opportunity to correct any misunderstanding regarding what information can and cannot be discerned from genetic testing. Strengths of this study are the high response rate, high percentage of minority responders, and that the patients were ascertained through a registry that does not bias toward inclusion of hereditary conditions. However, a significant limitation, which the authors acknowledge, is that the responses are self-reported. Therefore, it is possible that many patients with unmet need for discussion may have, in fact, had a discussion about genetic testing and why it was not indicated, yet they remained unsatisfied because they did not actually have genetic testing. In other words, they potentially confused lack of testing with lack of discussion. In summary, healthcare providers caring for breast cancer patients hopefully recognize the need for consideration of genetic testing in appropriate individuals and communicate that need to the patient. However, the corollary of recognizing that genetic testing is not needed and communicating that to the patient occurs less often, according to this study. Therefore, these results illustrate that a large portion of breast cancer patients, especially minority patients, may have questions about genetics, whether or not they specifically indicate so. Thus, a discussion about why genetic testing is not appropriate may be as beneficial as one about why it is, and oncology providers should consider briefly discussing genetics with all patients, even if the subject is provider-initiated. For those patients concerning for a hereditary predisposition syndrome, a referral should be made to genetics, and the patient should be informed why the referral is recommended. For those whose history is not concerning for a hereditary predisposition, the provider should very briefly explain the general indications for the referral and why this particular patient is not an appropriate candidate. By answering this potentially unspoken question, oncology providers may be able to reduce excess worry in this already highly anxious population. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.